research. So thank you so much for being here. And I will hope I will bring some light in the subject of alpha-1 exacerbation, just in case that someone in the room doesn't know what they are. And while I was getting ready for this presentation, I ran into this survey that was recently published by the COPD Foundation. It was a survey mainly done in cigarette smoke-induced COPD. It did not include any alpha-1 antitrypsin deficient patients, but they asked the same question to the patients and to the physician. And guess what a big surprise we had? We, the physician, think that in 98% of the cases, discuss with our patients what exacerbation is and what they should do when they have an exacerbation. Most of us think that we give and enable our patients with all the information and the tools, including medication and oxygen and devices that they need to have around when they have an exacerbation. And guess what? We find out from our patients. So in cigarette smoke-induced COPD, 62 of the patients interviewed didn't know a lot about COPD exacerbation. Moreover, 16% of them had no clue what an exacerbation is. So actually, this very piece of data is really disturbing, because if we think of alpha exacerbations in more familiar terms, just because cardiovascular medicine has been around for so many years, we can basically make a parallel between an alpha exacerbation and a myocardial infarction. So if you think that the myocardial infarction is an easy thing for a heart, we've learned for the past 20, 30 years that it's not. We've learned that the more you have, the sooner you're gonna die. We learned that if you have a severe enough myocardial infarction, you can die on the spot without having doctors around to help you. And we know that people who have multiple small myocardial infarction, they have bad quality of life. So it's exactly the same thing with the alpha exacerbations. If we don't know about them, if we don't treat them, if we don't prevent them, the short and the long term effects are going to be exactly the same as a myocardial infarction has on the heart, they will have on your lungs. So I will try in my talk to start very easily with their definition, then I will move through prevention. I will talk very briefly about the treatment, because it's not intended to be about the medical treatment, but I will spend more time in pulmonary rehabilitation, because I think that's something that we don't talk too much about it. And as I will show you at the end of my presentation, there is literally no data about pulmonary rehabilitation in alphas. So all we know about pulmonary rehabilitation is actually from cigarette smoke-induced emphysema. So let's move on. This is probably the only study done in alphas that looked at exacerbations and their incidence and their association with any known risk factors for exacerbation, like older age or female predominance or bronchitis. So I only put up here 2 data from this study, and on the left side, we'll have a graph of how patient reported exacerbation. So alpha patient describe their exacerbation as mild, moderate, or severe, and they're represented by different lines. We noticed a very small increase in the severe exacerbation line during winter periods, but most of the alphas described exacerbation throughout the year, and they had about the same amount of mild to moderate to severe exacerbation. Now, what do we learn about the same cohort of patients if we ask their doctor? What do they think? that their patients had. So is symptoms-based definition based on what alphas responded, or healthcare utilization-based definition of what physicians thought that their patients had. So the difference is that when we ask the physicians, we actually realize that because of the severe and moderate exacerbation, we have a higher cost than estimated by looking at the alpha response. So if we look at this curve, we will think, oh, okay, so we had some exacerbations, but that was not a huge burden on the medical system because the severe ones were as, the number of severe exacerbations was as high as the mild ones, so people didn't really go to the hospital. But then when we actually look at how much money the medical system has spent treating these moderate exacerbations, we realize the huge impact that worsening of exacerbation has on the healthcare system. And in a minute, we're going to see the effect on the long-term lung function. So usually, how do we define an alpha exacerbation? This is actually stipulated by both cigarette smoke-related COPD as well as Alpha-1 related COPD. Is a symptom-based definition, and it looks at these three symptoms. If you have increased shortness of breath or cough or sputum production that is out of proportion to your daily variation for more than 3 to 5 days, we call this an Alpha-1 exacerbation. Now, most of this exacerbation can be treated at home. People will say, yes, I had to take more bronchodilators for 3 or 5 days, but I didn't have to go to the emergency room, and I didn't take antibiotics, and I didn't take even prednisone. I didn't even call my doctor. So one would think that this is a very mild and non-important event in their disease, but soon I'm going to show you that that's not the case. We, of course, deal with other type of exacerbation when people try at the beginning, because of the increase in the same three symptoms, to treat themselves at home, or they call their primary care physician or their pulmonologist, and they get antibiotics or maybe just prednisone, or maybe antibiotics and prednisone, and they don't get better. Their symptoms continue to climb, and then they end up either in the hospital or in the urgent care clinic where they need either IV antibiotics or they need to get admitted. And this is when the medical system is actually able to have a good grasp of what that exacerbation meant to the patient and to the healthcare system. So most of the time, we as physicians or the medical system has no idea about this. They are self-reported. We sometimes miss them, and it's not good. You're going to see in a bit why. But we know about this, and we really try to avoid this as much as we can. And people have been concerned about the actual definition of an exacerbation. So there have been multiple publications of how do we define exacerbation. And because the exacerbation begins at home, it's very hard to come up with a different definition. We try to use blood tests, we try to use imaging, we try to use pulmonary function tests to readjust this definition, but so far, all the studies are still based on these three symptoms and worsening of these three symptoms to define an exacerbation. But what is behind these symptoms? So things that we don't discuss in the alpha exacerbation are actually the significant decrease in FEV1 that happens during an exacerbation, the significant decrease in daily activity and quality of life from the first green line to the second green line, And the fact that after an exacerbation, you take a very long time to either bring your FEV1 where it was, or maybe not bringing it at all, and noticing a very slow and continuous decline. So these are things that the current definition of an exacerbation don't account for. So we all know, yes, we're going to have worsening of symptoms, but we're going to take antibiotics and prednisone, and they're going to get better. Unfortunately, if you look the other way, this way, at the exacerbation, each exacerbation will going to lead to decline in your lung function, in your daily activity, and in your quality of life. So that's why it's very, very important to understand them, to prevent them if we can, to treat them, and let's see how we can do that. So the first step is primary prevention. That means that you never had, or you had maybe a mild alpha exacerbation, and we want to prevent you to have that very big, severe one that will require maybe hospitalization. So what can we do as primary prevention? These are very easy things. These are things we do in primary care office or in our pulmonologist office. So smoking cessation, very, very important, very important. I cannot emphasize how important it is to avoid even second or third-hand smoke exposure. That means not being around people who smoke, and that means not wearing clothes or being close to people who have been in a bar where smoking was allowed. So very important to avoid all kinds of smoke products. Vaccination, again, I cannot emphasize how important it is, both pneumonia and flu vaccine. Bronchodilators have been used to treat symptoms, to treat the day-to-day variability in dyspnea and cough. We can definitely increase the dose or the time or the amount of bronchodilators that we use during an exacerbation. Alpha-1 augmentation therapy has been shown to decrease the number of severe exacerbation. So being on therapy versus not receiving therapy puts you already in a better shape than other people who are out there either non-diagnosed or not started on augmentation therapy. Oxygen for people who need oxygen is actually the only medication in Alpha-1 or COPD that has been shown to improve survival. And pulmonary rehabilitation. And I'm not going to say more about this at this point in time because we're going to spend the last part talking about this subject. So the goal of this primary prevention is to actually avoid you going to the hospital. So we hope that by enabling you with this knowledge and having you prepared and have a plan what to do if you do experience a mild exacerbation, like having oxygen at home, having maybe a course of oral steroids, or having very easy access to antibiotics, will allow you to either treat the exacerbation at home or will allow you to just make a visit to our outpatient office and avoid going to the hospital. But that might happen. So what do we do if we have a severe exacerbation? The problem is that if we have one, we're going to have the second, and we're going to have the third. So the most significant risk factor for having recurrent severe exacerbation is having the first one. So therefore, if we did have one or we did have multiples, we need to do something more than the primary prevention, okay? So if we happen to have a severe exacerbation, we might need to be in the hospital, we might need to be on an oxygen mask, or BiPAP, we might need to actually be on a ventilator, on a breathing machine. We definitely need IV steroids and IV antibiotics because our gut doesn't work well when we are so sick. So, okay, so we take care of this severe exacerbation, but then what can we do to prevent the second and the third? So this requires a little bit more thinking and more partnership with your pulmonologist than the primary prevention. if the primary prevention, your primary care physician is going to be able to coordinate everything, I suggest that if you had a severe exacerbation, you get in touch with your pulmonologist, because we will need adjustment of your inhaled medication. This is probably the strongest indication for inhaled corticosteroids, especially that lately inhaled corticosteroids have been associated with increased risk of pneumonia. So you really want to make sure that if you are on inhaled steroids, it's for a good reason. Then people who probably required BiPAP or breathing machine while they were in the hospital might require BiPAP at night as well. So it will be important to get in touch with your pulmonologist, do an overnight polysomnography. This has been shown exactly like the oxygen to prolong and increase survival in patients who have high levels of CO2. Then there are several drugs, like the antibiotic azithromycin or the medication called Daliresp, that has been shown that added to your current medication will prevent the next severe exacerbation. But again, I think you should use this treatment only if you are in touch with your pulmonologist. And again, pulmonary rehabilitation comes as something that we should really do. And just to give you a number, 20% of the patients who were admitted with those severe exacerbations will come back to the hospital within 1 month. So that's really worrisome, and this is something that we should really be aggressive about and aware of, and avoid as much as we can recurrent rehospitalization. Now, I emphasized a lot pulmonary rehabilitation. So what is it, pulmonary rehabilitation, and why I think it's so important as primary prevention, as secondary prevention? It's because it brings together everyone who will enable you with different coping mechanisms to deal with the exacerbation at home, recognize them in time, and avoid the severe exacerbation. So it's a multidisciplinary team that happens in one setting. It's very convenient for the patient or the caregiver because you come once and you learn about everything. So it involves the Alpha-1 physician and the ambulatory nurse, a respiratory therapist, the PMNR doctor, which stands for pulmonary I have a problem remembering what PMNR stands for, but I will come back to it. Physical and occupational therapist, dietitian, psychologist, and in specific center, the lung transplant coordinator is also involved because some of the people will eventually need a lung transplantation evaluation, and they need to know how good they are in pulmonary rehabilitation to make that decision. So what can pulmonary rehabilitation do in Alpha-1 exacerbations? So I think I look at pulmonary rehab as a holistic approach. It can help you deal with the acute exacerbation. It can help you get back to your baseline. It improves daily activity. And it can definitely help you deal with worsening of your condition. So let's see how pulmonary rehab program can actually achieve these goals. So the first goal was to help you deal with the Alpha-1 exacerbation. And I cannot emphasize how important it is to have a refresher of so-called action plan from the respiratory therapist, and then from the ambulatory nurse, and maybe from the pharmacist and the dietitian, although you hear it for the first time from your doctor. So having a plan and having a refresher about what that plan means, it's really, really important. For people who don't know what an alpha-1 exacerbation is, they will find out for the first time. They will learn to actually recognize their symptoms. Thank you. So PNMNR stands for Physical Medicine and Rehabilitation. I apologize, I really missed this one. Okay. So they will teach you about your symptoms, because we don't want to overtreat the day-to-day variation in your symptoms. We really want to act aggressively on the symptoms that are above your daily variation. Most of the treatments for the exacerbation involve steroids and antibiotics, and we don't want to overdo this type of treatments. So that's why it's very important to be aware of your baseline level, and definitely in pulmonary rehab, the discussions that you have with the nurse and the physical therapist and the respiratory therapist will help identify those baseline symptoms. During a pulmonary rehabilitation program, you can also gain a lot of insight in when it's time to get referral to the lung transplant program, and how is that gonna affect your life, as well as if we approach the level of disability and severe physical impairment, as well as sometimes cognitive impairment. A pulmonary rehabilitation program, because it includes a psychologist, can help you make end-of-life decisions. The next goal of a pulmonary rehabilitation program is to increase your daily activity, especially after a hospitalization for a severe exacerbation. This particular goal of the pulmonary rehab is very, very important. So what I tell my patients is that one day in the ICU, it's equivalent with 1 week in pulmonary rehab. So you lie in bed for 1 day, either on BiPAP or on a breathing machine. That means that you're gonna have to work out a week in rehab to gain back the strength that you had before the exacerbation. So we are not talking about improvement, we are talking just about coming back to your baseline. So pulmonary rehab program will work with you to get endurance and strength in both limb muscles, but most importantly, training these respiratory accessory muscles that are very important in people who have severe emphysema and hyperinflation. In severe emphysema and hyperinflation, the muscle that helps you breathe, the diaphragm, is in a pretty bad position. It doesn't really move because you just have too much air in the chest. So then these accessory respiratory muscles, which are mostly the neck muscles as well as the intercostal muscles, become your they'll be the muscle that will save you from experiencing severe dyspnea. So the respiratory therapist, physical therapist, and occupational therapist will help you gain a lot of endurance and strength in these muscles by teaching you different breathing techniques and weightlifting and other type of exercises that really address these particular muscles. Now, as I said, we know a lot about pulmonary rehabilitation and how this can help people with COPD, but this is all in cigarette smoke-related COPD. The only study that I found in alphas is actually an abstract presented at the last year national conference, ETS, that looked at specifically at Alpha-1 patients, and actually the results are worrisome. Because in this particular group, they had matched number of cigarette smoke-related COPD patients, and they've seen that in alpha patients, they had smaller improvement in exercise capacity, and they had less positive adaptation in skeletal muscle. So when you develop endurance and strength in these muscles, you have changes in the fiber muscle, so they can take a biopsy to actually assess for those changes. They did that in these alpha patients, and they did not find them. So even if you are part of a pulmonary rehab, there is a reason why your muscles will still be weak at the end of the pulmonary rehabilitation program. And definitely that's a subject that I am interested in, not particularly in it, but it's a very interesting finding. While alpha patients will not develop or will not have increased endurance and strength proven by muscle biopsy. So we have a lot of work to do. Now, the last thing that I want to tell you about pulmonary rehabilitation is how this program can improve quality of life. And I think the main point of this slide is that it teaches you coping mechanism, but not only the alpha patient, but also the caregiver, which in very severe cases of emphysema becomes the person that is the most important, probably more important than the patient, because they have to make all the decisions and they have to make sure that actually the alpha patient is adherent to the medication, knows and monitors the symptoms, knows the physical limitation, like not going to the mailbox without the oxygen or not climbing the 2 flights of stairs without oxygen, helps the newly diagnosed patients avoid the social stigmata, not so much in Alpha-1 probably, but a lot in cigarette smoke-induced COPD, where people see their disease as a self-inflicted disease and they try or they tend to take upon all the guilt, which might be true or not. The problem right now is that they are sick and they need help. The pulmonary rehab can also give you a lot of insight of what you can do or cannot do at your job, and can help you coordinate with your employer, maybe changing in your job description to avoid being on disability if you consider to continue your job. It can help you with home relocation. There is all this discussion that instead of moving to Denver and having to wear oxygen, I'm just gonna go to Santa Barbara and I'm not gonna wear the oxygen. So it's very important decision when you find out that you have advanced emphysema. And then again, I cannot emphasize how important it is to have a plan when you are not awake and alert to make a decision for yourself. Now, discussions with the psychologist, with the lung transplant coordinator and your doctors are very important to know what to do when we get there. And of course, quality of life is also dependent on dietary recommendation. There are people who have severe emphysema and might be overweight. Most of the time, people with severe emphysema are actually malnourished. So it's very important to know exactly what you need to eat to match the energy expenditure. People will say that if you are a very active person, you have to keep up with your carbohydrates. In people who are sedentary, carbohydrates might be dangerous because if you don't burn the calorie that you eat, you're gonna transform them in CO2 and you're gonna worsen the CO2 retention. So that's why engaging with a dietitian and a physical therapist will actually determine the activity level that you can do and will teach you how many carbohydrates and how many proteins and how many lipids you can have a day. So I hope I convinced you that pulmonary rehab is actually something that we should look forward. In alphas, we should probably evaluate it better only in alpha patients. Maybe we need to change things. Maybe things that we do in cigarette smoke will not apply to alphas, or maybe we need to add and more things from alphas to the general pulmonary rehabilitation indication. So it's definitely something that I'm looking forward, and I hope that we will put some effort in researching, and it's mainly clinical research, so I don't think it's going to involve a lot of money, but there is a great interest to actually start pulmonary rehabilitation in the hospital. So that's something really, really important, instead of letting patients go home and spend another week or two to recover until they actually start the physical therapy. So very, very interesting and hot topic, and I hope we're going to have more answers in the coming years. So with this, I'm just going to leave you with my take-home points. You have to recognize, you have to treat and prevent the alpha exacerbations, because they have tremendous short-term and long-term impact on your lung function and daily activity. And pulmonary rehabilitation is actually insufficiently used in Alpha-1 patients. I think it's insufficiently used in COPD, cigarette smoke COPD as well. So now that we all know about it, we will change things. And with this, I want to thank you, and I hope everyone has the energy to do some exercises with me. Thank you. If you have any questions. Yeah, so Gary has asked me what's the difference between a moderate and severe exacerbation, and that's a very good question. If you think that we have a better way to define that, then we have to actually define the exacerbation. You are wrong. So as of today, the way the doctors or the medical system thinks about moderate versus severe exacerbation is just the settings where this happens. So if you need IV antibiotics or steroids, or even oral antibiotics and steroids, but you stay home, we call it moderate. If you need to go in the hospital, we'll call it severe. They also try to emphasize how many symptoms you have. So if you have 1 symptom out of 3, they might call it mild. If you have 2 out of 3, they might call it moderate. And all 3 together, severe. But I think because we know that you can have them all and still be home, and we will not know about them, the most accepted definition or difference between moderate and severe is actually where you get treated. If you stay home, you are moderate. If you go to the hospital, it's severe.
As a follow-up to that, I don't see fever. 104 fever would be...
That's a very good point. And this brings us back to this. So there are so many things going on along with an alpha-1 exacerbation that we don't account for. So the definition is really, really simple. It's a bad definition. It's a very easy to use definition, so I think that's why we got hung up on. Every time when we try to change it and we try to add more things to it, everything gets very complicated. We cannot use old data to compare with the new data, because the old data was all based on the old definition. So it's going to take years of practice changes to incorporate fever, to incorporate daily activity, to incorporate FEV1 decrease in the exacerbation definition. But we are working on it, because we all know that it's a bad definition.
When you, as a follow-up to that, when someone leaves the hospital, what would you define as recuperation time?
That's another very good question. So I would say that your best chance for the lung function to come back where it was is probably 3 to 6 months. I will give it probably longer than that for your daily activity, especially if you're in the ICU. So if you're in the ICU and you are lying in bed, it's going to need months and months and months of physical rehabilitation and just working on your own at home to get back where you were. And most of the time, you are not. Most of the time, you are just going in this trend of going down, down, down. So that's why it's very important to treat them. I think it includes everything. Yeah, so the lower your FEV1, the more short of breath you'll be, the less activity you do, and the more miserable you feel. So there is a myriad of systemic symptoms or diseases associated with alpha-1 deficiency that we don't know how to treat. We just discussed this morning that for the necrotizing paniculitis, like the skin finding that some people with alpha-1 deficiency develop, you need a higher dose than the one we administer to people with lung disease. So it might be that indeed we do have fibromyalgia or muscle pain and weakness associated with alpha-1 deficiency. We might need higher levels of the augmentation therapy to treat that condition. But so far, we don't know how to diagnose it. We are so far behind. So we are not very good at finding the right tool to identify these systemic manifestations of alpha-1 deficiency. That's a very good point. Most of the natural products have immune booster of the immune system. Unfortunately, your immune system by itself is able only to clear viruses and not bacteria. So if we go back just one slide. So if you experience an exacerbation and you think, that's it, I'm just going to take a natural product. If at the beginning of this exacerbation you had a viral infection, you might get lucky in just taking extra bronchodilators and natural products. You might get over the exacerbation. But most of the time, if your immune system is not able to clear the virus, then the next step is to get a bacterial infection. That will not go away without antibiotics. Yes. One more question, yes. Okay. It's because of the way we define exacerbation. So if you tell your doctor that during your cold you had worsening cough or sputum production, that to us signal that you had an exacerbation. It's just the definition. And maybe your cold was mainly viral and you just got over it in 5 days. But that counts too. That counts too, because having 1 or 2 colds a year, so we're talking about just viral minor stuff, nose, eye symptoms, is normal. And actually for someone who is on alpha-1 replacement therapy and on the right inhaled treatment, that signals us that they work. So if you have 1 or 2 a year, then that's perfect. You should not get worried if your doctor dictates in the note, oh, Mrs. So-and-so had 1 exacerbation per year. That for us, it's a good sign. We document that actually the therapy that we use is working. We have to do that. If we start using numbers like 3 or 4 a year, then that's concerning. Right.
We're working on it.
Yes.
We're working on it.
Right now, no.
One of the goals of the foundation.
Yes, I think the only thing that we managed to get from Medicare was to have, so if you are more than 1 year from your last pulmonary rehab visit, you can have a refresher, but that means a one-time visit to maybe re-show you how to do lip breathing and how to use your inhalers and how to measure your peak flow. But yes, unfortunately, this is where we are at right now. And then the second big disadvantage with pulmonary rehab is that because it's in one place and it's not at home, it implies that you have to drive there. And it's very hard for most of the patients, so that's why you need a caregiver again. So suddenly you don't take away only the patient from a productive life, but you take the caregiver who has to go with the patient for these sessions. Yes, these are big, big step downs, and I don't think we have an answer.
So I'll put a couple of commercials in. Number one, if you have the Big Fat Reference Guide, the BFRG, or access it on the internet, one of the appendices is how to recognize an exacerbation, how to recognize when you need to call your doctor, when you can treat it at home, when you need to go to the emergency room. Just guidelines, general guidelines about that might help give you some, flags along the way that tell you when you need to be concerned. And the other thing is AlphaNet has developed something called virtual pulmonary rehab. Any of you that have been in the Step Forward study may have been exposed to that. We're waiting to do the analysis on the data that we generated from that study to see whether this virtual pulmonary rehab that involves videos on CD that you can watch and sections that you can do at home in a well kind of defined way in a little briefcase actually gave benefit to patients. I can tell you that we've analyzed the data. We simply haven't unblinded the groups, and we're going to be very disappointed if the group that we think got the treatment isn't the one we think, because some of the data looks really promising. So it may be that avoiding pulmonary will turn out to be better, but the data will be the data.